Essentials of Health Information Management, Principles and Practices, 2nd edition, Chapter 6, Content of the Patient Record, Inpatient, Outpatient, and Physician Office Records. This presentation is going to focus on the meat of the record, what's inside that record, the documents that make up the medical record. So this is going to be a very important chapter, a very important presentation. I'm going to refer to quite a few of the figures and tables in this chapter, so it may be good for you to have your book as I go through the chapters, because I'm going to speak to a lot of those. So be patient with me, because it will give you a visual of a lot of the documents that I am describing from this chapter. So pay particular attention to these different documents. This is a cornerstone of the profession and what you're going to do. Everything is based on this record. This is a very significant presentation. So documentation in the record is also very important. A lot of things in this presentation and in this chapter, they point to the different standards that we are in compliance with. There has been much discussion in this course about complying with different standards, be it federal, state laws and regulations, your accreditation standards, your Medicare conditions of participation. So this presentation, this chapter is going to refer to that quite a bit as to why we have certain documents, why we do things the way we do. Beginning with those documentation, which is very important. Joint Commission and your conditions of participation have a lot to say about that. Joint Commission requires that the record contains patient-specific information appropriate to that care, treatment, and services provided. Your conditions of participation say that we need to have some sort of administrative responsibility over that medical record, some type of medical record service, hence your health information department or your medical records department. We're going to maintain those records. We got to have a process and procedure in terms of author identification and as to how we're going to maintain those records. We also have to have information within that record that is going to justify why that person is being admitted to that facility. Everything in the documentation must be legible and have to be authenticated, dated, and complete in a prompt manner. We also have to retain the original, according to your CMS, your conditions of participation, or legally reproduced form for a period of at least 5 years. We have to have a coding and indexing system in place, and we also have to ensure confidentiality. So your Joint Commission and your Medicare conditions of participation have a lot of parameters on our documentation process. Amongst that, we also are required to have patient identification on the information or on the documents in the record. As a matter of fact, your patient identification as well as your facility identification needs to be on each form or every screen, if it's an electronic record, front and back, so on both sides. Your book also brings out a important point when you have, say for instance, very famous individuals who are admitted into a facility and they want to go by an alias. This is fine. This can occur. However, you're going to maintain their official name in your master patient index. But also, this may cause a problem for that particular patient in terms of reimbursement. And a lot of times, your insurance companies will not reimburse for admissions that's using an alias. So this has to be acknowledged by that patient that they're going to be responsible for that payment in the event that occurs. Also, what you may see in terms of your book, if you look on page 122, figure 6.1, this is what we call an addressograph machine. Some facilities may use this machine in which they create imprints on all of their forms, so they get the facility information and the patient information on each form. And so what they use is almost like a credit card. Those old-fashioned, when you put your credit card in there in the little form and you go across it real quickly and it makes an imprint. This is similar to how this addressograph machine works. So they have these little plastic cards with the information on the card, on that plastic card, and then they take the form and put it on there and they press it down and it makes that imprint. And so basically this is just for making sure that patient identification or that facility identification is placed on all the reports in the record. We also talked about in earlier presentations about the dating and the timing of patient record entries. We have to have a date on all the entries and the time, and we want that to be done as soon as possible after the care and treatment has occurred. We cannot predate or post-date entries. This will be improper. We are also very concerned about quality. We want to make sure that the documentation that's going in the record is of quality nature. Table 6.1 on page 123 gives us several things that we take into consideration in terms of our documentation. We want to make sure everything is documented and signed. If we want to document any changes that occurred in that patient's condition, if we have any communication or dialogue with family or other providers, that needs to be documented in that record. We want to make sure everything in there is complete. If there is some issues in terms of completeness, we want to amend that entry according to the guidelines that we have been given in a previous presentation. We want everything to be consistent, so that means if we have some type of documentation in there, it should be consistent with any lab tests that come through, flow charts or anything else. Everything should make sense. If there's something contradictory, then there should be notation or explanation of why that is. We also, when there are forms in that record, say, for especially like with progress notes, if providers are documenting in those progress notes and they want to fill up the whole sheet, if not, the part that's blank should be crossed out so that no one can insert different things. One thing about a lot of blank spaces, that is not looked upon favorably. Say you're in some legal matter, it looks like it may have been some tampering going on, so we do not leave any blank spaces on forms. We also keep our documentation objective, meaning we don't insert our opinions in that documentation. If we have to make reference to other patients, then we are not going to call those patients out by name in another patient's record. You may possibly use that patient's medical record number or reference number instead. We also learned that everything we place in there is going to be permanent in nature, so we do not obliterate any information. In terms of the type of paper, we usually use white paper with black ink. Basically, we're going to be interested in readability of those records, and the ink should be permanent, plain paper. We use original documents, not photocopies. We want to be careful of attachments on things, making sure because they can fall off. And we don't want to be vague in entries. We are very specific. So the Table 6.1 does a good job of a lot of those documentation guidelines that are important in a record. Now, in our record we talked about we have administrative data and we have clinical data. When we look at administrative data, we have several reports that fall under that classification. That will be like your face sheet, your advance directives, your consent, your patient property form, your birth certificate, and your death certificate. Now, face sheets, they are that form you usually see, is usually the first form you see in a record. You also have an electronic record, something equivalent, like an admission screen that's equivalent to a face sheet. Figure 6.2a on page 125 is an example of a paper face sheet, and then on page 126, figure 6.2b is an example of an electronic screen that serves as a face sheet. If you look at that closely, you see patient demographic information is on that sheet. You also see where they can list diagnoses and procedures that that patient is undergoing or that they have. You also see that you can tell who the attending physician is on this form. So they do place the admitting diagnosis here. Now, the thing about an admitting diagnosis is that this is what they come in with. That's not necessarily going to be their discharge diagnosis. Your admitting diagnosis is before any kind of study has been done versus the patient's final diagnosis, which is determined after evaluation. Your attending physician establishes that admitting diagnosis. This is going to go on the face sheet. You also need to be aware of data sets, and we're going to talk about two big important ones in this presentation. But when we're dealing with hospital information, hospital records, they use what we call UHDDS, or your Uniform Hospital Discharge Data Set. All that's saying is what is it describes the minimum set of data that the hospital has to capture or obtain on an admission. All right, and so your book there on page 124 gives you a list of those items that are minimum. This does not say this is all that they'll collect, but this is the minimum amount that they need to collect. Your National Committee on Vital and Healthcare Statistics, NCVHS, also has recommendations on what needs to be collected as a standard data set for people or patients in an ambulatory inpatient setting, and there has a list there. You can read those on your own on page 124. Financial data is also included. If you look on your inpatient face sheet in figure 6.2a on page 125, if you look in that right-hand column, go down a couple right beneath where it says next of kin, name and address. You start going further down there, that little section, primary payer, secondary payer, so it does capture your financial information as well for the patient. Table 6.2 on page 127 gives a breakdown of your demographic information and your financial information and clinical information that's captured on the different sections of your face sheet. So you can look at that as well. Okay. Advanced directives. I'm jumping ahead of myself here. Here we go. Advanced directives are also considered administrative data. Under what we call the Patient Self-Determination Act, PSDA of 1990, this required facilities to notify patients who are age 18 and over that they have a right to an advanced directive. So what they have patients do to sign an acknowledgement form regarding the laws on advanced directives and those facility policies that they have in place regarding advanced directives. So what usually happens is they give them that form upon admission, and that patient signs that acknowledgement about those advanced directives. And if they actually want to put some of those directives in place, according to the PSDA Act, they can sign those and place those on the chart. These need to be there before they need medical treatment. If you look on page 130, figure 6.3, this is an example of an advanced directive admission form and checklist. In Table 6.3 on page 131, it gives you some examples of what we mean by advance directives. So that includes your DNR, or your do not resuscitate order, your living will, and your healthcare proxy or durable power of attorney. You have pictures of those forms. Figure 6.4 will be your DNR. See that there? And then Figure 6.5 on page 132. That's your living will. And then Figure 6.6 on page 133 is your healthcare proxy. You need to look over those and see the type of information that is included. And you usually have a statement there about what they want to occur about their healthcare. Informed consent is also an administrative type form. And basically, your joint commission states that evidence of appropriate informed consent needs to be documented on their record, and the facility has to have policies in place in regard to informed consent. For procedures and treatment, there should be evidence of informed consent. Your Medicare COP states that all records must contain written patient consent for treatment and procedures specified by the medical staff or federal or state law. All right. So when patients sign an informed consent, they are consenting to the treatment options. This has to be documented in the record. Those informed consents should have an explanation of what types of risk is to that patient, and this should be discussed with that patient once they sign this consent. So they should have discussed this with the patient about those risks, what type of benefits they're going to receive from that procedure. Are there any alternative procedures that they can have? Evidence that their patient or appropriate legal surrogate understands what has been told to them, and they consent for this treatment to happen. And I meant to mention, let me digress just a little bit. Figure 6.7 on page 134 is an organ tissue donor card, which is also under your advance directive. So I apologize for that. But your consent, you have a consent to admission as well, which is different from your consent to treat. Your consent to admission is a generalized consent, basically saying I'm allowing this facility to treat me. So it's nothing specific like a consent to treatment. Consent to treatment is like a basic procedure that's going on. They're going to explain to you the ins and outs of that procedure, and you're going to sign that consent. HIPAA does not require a facility to get a consent to admission to be signed, but a lot of times facilities still do that. You also sign consent for release of your information. However, if the information is being released due to treatment, payment, or operation, a lot of times we call it TPO. I think your book says for the purposes of reimbursement, research, and education. HIPAA says that the facility is not required to get a consent to release of information for those things. So basically, they don't have to get consent for in regular business or regular operations of using your information and releasing your information. Okay, but of course, other things outside of that, they do have to get an authorization from the patient. If you look on page 134, figure 6.8, that is an example of a consent to admission. And figure 6.9 is an authorization for release of information. That's on page 135. Make sure you take a look at those as well. You also have other special consents that a patient can sign for different types of surgical treatment. And the patient will acknowledge it using an informed consent form. You should see patient's identification, what type of treatment that they're looking at, and your potential risk, benefits, and side effects. We already kind of talked about those. I don't think that they have an example of that form. Oh, well, yes it is. Figure 6.10 on page 136. Again, there's a lot of figures in here. I'm trying to make sure I point them out as we talk about each one. So figure 610 shows the consent to operation or procedure. You see how it looks very different from your figure 6.8, which is a general consent. This is a lot more specificity going on here that the patient is signing off on. All right, so the next type of form that's also considered administrative form is your patient property form. You'll see this in hospitals and when you're admitted in an inpatient or overnight stay, and you'll fill out this form where they'll have you sign this form, and they sign off on this form where it lists out what type of property you're bringing in to the facility with you. So the hospital staff and the patient signs this form. Kind of making sure we keep down confusion in terms of making sure that something goes missing or something. We already have a listing. They already have a listing of what your personal property is. On page 137, figure 611, this is an example of a patient property record form. Okay. Now, other things we have here are your certificates of birth, certificates of death, or your death certificates, birth certificates. When a baby is born, then they fill out a what am I trying to call it? They fill out a application for a birth certificate, submit it to the State Department. Sometimes they will put the actual birth certificate on the record, and sometimes they just put the application for that on there. And so this is through your National Center of Health Statistics, NCHS. You also have several things that they include on a birth certificate. Infants and parents' demographic information, parents' occupation, education, ethnicity, race, pregnancy information, medical risk factors and complications, abnormal conditions of the newborn. Then you have death certificates. Same kind of thing. This goes also to your NCHS. Your state health department. When someone dies, then they put that on the record. Basically, some information about the person who died, their family cause of death, disposition of the body, those types of things. And they usually have to file this with the State Department within 5 days. And then it gives you a bulleted list of the kind of information that's contained on your death certificate. Let's see, I believe they have figure 612 and figure 613 on page 138, 139 showing standard birth and death certificates, because your NCHS has a standardized form that states can use if they like. So there's a copy of that. All right, so that is the gist of your administrative data. You also have clinical data in your hospital inpatient record. So basically, we're kind of looking at a hospital record more or less than any other type, because it has all your documents. So we just look at the administrative data. Now we're looking at clinical data, and clinical data results from treatment of the patient. That's what's making it different from administrative. Administrative is obtained from other than treatment. So in terms of your clinical data, your book starts talking about your emergency department record. And there are guidelines through Joint Commission on your emergency documentation requirements for your emergency room record. And it also, one thing it tells you about that record is that it has to, once that emergency record is completed, it should be sent to the provider who administers follow-up care. So things that go on with the emergency department record, and you can look at figure 614A as an example there, that they include what the patient's disposition was when they came in. They put discharge instructions on that record. If they came in through the ambulance, then your EMTs will also have also document information on that record. So they'll put their report there. Also, they bring your attention to what we call anti-dumping legislation in terms of your emergency department. If they are licensed to provide emergency services from transferring patients who are unable to pay to other institutions, they have to take those patients. So they can't turn anybody away who's in an emergency situation. They have to at least stabilize them before they transfer them. So that's what that anti-dumping legislation is about. They can't, because they can't pay, they can't bar them or refuse to treat that patient. Figure 614B on page 142, it shows an example of discharge instructions for emergency department patients. So that would go in emergency department record. And then figure 615 on page 143 shows an example of an ambulance report that we just talked about. If they come into the emergency room via ambulance, this is a report that they would fill out. Now, a very important document on the record would be your discharge summary. Another way they also call it a clinical resume, and basically you also have information about that through Joint Commission and your Medicare conditions of participation. It tells you that discharge summary is going to be completed by the attending physician. They're also going to complete what we call a final progress note. If that patient has minor problems and wasn't nothing major going on, we can get away with just a final progress note. Usually you're going to see those on what we call short stays, less than 48-hour stays in the hospital. They can get away with a final progress note versus a full discharge summary. If that patient is transferred to a different level of care within the same hospital, then you're going to call that a transfer summary. Your Joint Commission requires the use of approved discharge criteria to determine the patient's readiness for discharge. So basically that's saying they have some protocols laid out to determine whether they can discharge a patient. Your Medicare conditions of participation state that all records must document a discharge summary, which includes the outcome of hospitalization, disposition of the case, and follow-up provisions. So these are the rules and regulations that outline why we have a discharge summary. We use it for continuity of care. Most often, when a patient is moving on to other levels of care or what have you, or to a primary care physician, if they're going back for follow-up care, most of all these places that occur after they are discharged are going to request a discharge summary. That will, because it summarizes the whole patient admission. And so a lot of times they can just use that without having to request the entire record. The discharge summary fully and accurately describes a patient's condition at the time of discharge, any education that they were given, discharge instructions, and your book gives a nice bulleted list there at the bottom of 143 on what you will see in a discharge summary. Admission, discharge date, reason for hospitalization. If you look on figure 616 on page 144, this is an example of a discharge summary. Now what I would like to mention to you is not to get hung up on how it's formatted, because depending on what facility you are at, a discharge summary may not appear like this. What's important is the type of information that's collected in a discharge summary, and that's how you can tell what a form is. So I can possibly give you some forms without the title. You should be able to look at that form based on the type of information that's being collected and can be pretty accurate on what type of form that is. Okay. Let's see if there's anything else I want to say about the discharge summary. And I think that's about all I want to cover with that. Now, your history and physical is another important form that we have talked about on several occasions. And, of course, your drug commission and your Medicare conditional participation have standards for your H&P. And this should sound familiar to you because we talked about this before. Your H&P must be performed and documented in the patient record within 24 hours after admission and can be placed on the record within 24 hours after, I think I said that, within 24 hours after admission. Or if the hospital and physical examination was completed within 30 days prior to admission, it can be placed on the record within 24 hours after admission. If they can't do that, if they can't satisfy that or put it in there at the, within the time that is required, they can put a handwritten note with the pertinent findings in the record and place it there until they get that on the record. All right, and basically, so a history and physical, it can't, like if you are in like a physician office record, that it be separate. So you got a history, it's actually a history that's done, and then you have a physical. When we look at just the history, that's going to include what we call your chief complaint. That means what that person is coming in for, your HPI or your history of present illness, and then your past family and social history, as well as a review of systems. That's what is included in your history. You will hit on that quite a bit when we do CPT coding in terms of those and how we code those. So you got your history and then your physical examination. If you look, your history form on page 146, figure 617, shows you what just the history portion looks like. And table 6.4 on page 147 gives you the descriptions of those different elements of a history that I just talked about. And then if you look on page 149, figure 618, this is an example of a physical exam. That's the physical exam of your H&P or your history and physical. That's all the same. History and physical exam, history, physical examination. Now you may also see what we call an interval history, and basically this is documenting that HPI and all those things and any pertinent changes that have occurred since a previous inpatient admission. Basically, with an interval history, what happens is once that patient is discharged, if they come back within 30 days, then they can do what we call an interval history, where they're just updating the history that was done at the first admission. All right? So I showed you the figures for your history, figure 617, and then your exam is figure 618. And physical exam is just what it sounds like. If you look at that form, you see how it goes through all the body systems and body areas, and they're checking off whether they are finding anything, whether it be positive, negative, there. What's interesting to note, and your book brings out, is what we call a differential diagnosis, looking at all your possible diagnoses, basically. So they have not nailed down a definitive diagnosis, and so we call it a differential diagnosis. Your book also gives you a good note there on the bottom of page 148, saying that your house staff can actually perform a history and physical and dictate the report for that. And the house staff member signs the report, and then your attending physician is going to review that report to make sure it's complete, and they're going to authenticate that report. And you also can find on your record, which is also clinical, is a consultation. Basically, a consultation is going to occur when a physician requests an opinion or advice from another physician. And your drug commission tells you you should document any consultations using a consultation report. So once that physician comes in and evaluates that patient, and then they're going to complete a consultation report. with their opinion and findings once they looked at that patient. This is going to go on the record. So we should see in the record somewhere where the original physician initiates the consultation, and then we should see where the consulting physician does his review and documents his findings in a consultation report. All right. Another type of clinical document is for physician orders. There are a lot of different types of orders, and basically a physician order is similar to when it's similar to like with a medication, a prescription for medication. So when he fills out a prescription, this tells the pharmacist that they can fill this medication for you. Physician orders work the same way. Everything that's being done in that hospital in terms of treating the patient is initiated by an order from the physician. All right, so they can have diagnostic and therapeutic orders according to your Joint Commission standards. They can have verbal orders or telephone orders. They have to be authenticated by that physician, and your facility will have policies in terms of what's the time frame on them authenticating those orders. And your orders have to be supported through the documentation in the record. Well, let me digress just a little bit. Again, this chapter is chock full of figures. 152, page 152, figure 619 is an example of a consultation report. All right. So let me move forward. I hope I didn't confuse you. So we were talking about physician orders and how they work. Now, we talked about what Joint Commission has had to say on your physician orders. Your Medicare conditions of participation says that all physician orders have to be legible, complete, and authenticated, dated, and timed promptly. All right? It's also acceptable for another practitioner responsible for the care of the patient to authenticate the order, even if the order did not originate with that practitioner. This is Medicare conditions of participation on what their rules and regulations are. So you got to have complete, legible, date and time, authenticated orders. On page 154, Table 6.6, they give you a list of all the type of orders you can see in a record. You have the discharge order, and basically this is the order to discharge a patient. So this initiates that process for them to discharge a patient from the hospital or inpatient facility. If that patient leaves before time or before they actually discharge them, then they need to sign what we call an AMA, against medical advice, and this kind of covers the butt of the facility in case something occurs due to them leaving before properly discharged. Joint Commission requires them before they discharge the patient, obtain a medication history from that patient. Prescribing medications based upon review of that medication history, compare and prescribe admission medications. This is a medication reconciliation. Compare and prescribe admission medications to those on the medication history, resolving any discrepancies. And even after discharge and transfer to someone else, they continue with that process, basically making sure that the medication list is complete, up to date, and appropriate for the patient. So this is all involving when they get ready to discharge that patient. So you got that's a discharge order. Then you got your routine and standing orders. Basically, these are ones that kind of don't change or occur all the time, are very common. And so what they do is it's already laid out, pre-approved, pre-printed, and they place it on the chart. So when certain patients come with certain conditions, there's already a certain protocol that kind of happens when that triggers that one, and they just place it on the chart. So that's kind of your routine and your standing orders. Actually, 620A on page 155 is just a blank example of a physician order, and 620B is an example of a standing order. All right. Then you also have what we call a stop order or automatic stop order, which kind of is like a acts as like a safety mechanism. Where they have certain situations that are pre-approved, where pre-approved standard physician orders are automatically discontinued, requiring the physician to document a new order. So that's what we call a stop order. Then you got your verbal orders, your telephone orders, sort of all kind of work the same. But they tell you here that very important for you to pay attention to when a authorized member provider is taking their verbal or their telephone order. They do what we call a RAV, a read and verify process, where once that physician or provider tells them what is needed in terms of that order over the phone, then they need to read back and verify what was said. All right, and they call it read and verify. You got transfer orders if the patient is going from one facility to another. I already kind of mentioned about verbal orders that the physician will call in or whatever when they're not able to be there. But of course, with these, the facility usually lays out a time frame in which they have to come and authenticate those orders. Then you got your written orders. They are handwritten or enter into an electronic health record, which is your common order type of order. Okay? Make sure I haven't missed any of the nice figures. Okay, very good. So the next thing is we want to talk about is your progress notes. I'm just looking. Figure 621 is a picture of your progress note or your illustration. That's on page 159, if you want to look at that. All right, so progress notes pretty much kind of tell the story of what's going on with the patient. And if you look at it, so it's just like a blank kind of sheet, but you got all of your different areas in the hospital that sort of document progress notes for the patient. And it helps for each department to communicate with one another. So say maybe that patient is going over into the therapy department. They can see what the nurses did that morning or the day before. Because it kind of provides that chronological picture. It helps with the continuity of care for that patient. And so all you got admission notes, you got follow-up notes, discharge notes, all those go into your progress notes. On table 6-7 on page 160 and 161 tells you all the types progress notes that you can see in a record. You got a mission note. That's where your attending physician documents why that patient came in, with the brief HPI, the patient care plan, all that kind of stuff, physical assessment. You got a follow-up progress note. This is where they're documenting your daily progress notes on what's going on with that patient every day. You got discharge notes. And we kind of briefly talked about that when we talked about discharge summary. When we talk about that final progress note, this is what we mean by discharge note. Case managers, they also have notes that they put in that's regarding the discharge plan for that patient, because they help pull that together, where they're going to go, do they need any durable medical equipment, wheelchairs, whatever else they need in order to be discharged, do they need some kind of education. You got your dietitian that also documents notes in the record about the patient's dietary needs and any observations regarding the patient and their diet. There's a note there under your dietary progress note for joint commission. Dietary orders are to be documented prior to serving the diet to the patient. All right? And it has to be in accordance with the physician's orders. Now you also got a rehab therapy progress note. So these are your therapists, like your occupational, physical therapy, speech therapy, that document in the record. They document their therapy goals. Why was that patient referred to rehab? What's their condition? What's the goals of the therapy that they're going to execute for that patient? Then they're going to document progress of that patient with those. Are they achieving the goals that we set out? How long do we think it's going to take for them to complete the rehab therapy and be to some sort of functioning that we're expecting? You got respiratory therapy progress notes. So this is your therapist, respiratory therapist, who document in this area. They document what kind of therapy they're using, the type of machines they're using, what kind of medicines they're putting in those machines. Do they have prescriptions? Have they had any adverse reactions to it? Those type of things. You got pre-anesthesia, post-anesthesia notes. So when a patient is going to be using anesthesia in some type of surgery, you got to have a pre-note on anesthesia. Basically, and it has to be like an anesthesiologist or a CRNA who documents this prior to them administering that anesthesia to the patient. So they're documenting when that patient comes in for that first interview, what they say about that patient's physical status, any diagnostic tests that they completed to help them get a better picture of that patient's physical status, what type of procedure are they getting ready to use that anesthesia, and any potential problems that they may see. That's going to go in your pre-anesthesia evaluation note. Then they're going to also do a post one. So after the surgery is complete and the patient has finished using anesthesia, they're going to also document the condition of that patient at that time. Was there any complications during that operation, and all their vital signs and whatnot? They're going to be documenting that post-anesthesia note. I think you have, let's see, pre- and post-anesthesia evaluation record, figure 622B on page 164. You also have on page 163 an anesthesia report, figure 622A. You also have pre-op and post-op notes. So now your pre-anesthesia and post-anesthesia is not only the same thing as your pre-op and post-op. So you got your operation, your op notes, as well as your anesthesia notes. So the op notes are going to be documented by your surgeon, all right? And so in your pre-op, they're going to summarize the patient's condition before the surgery. In your post-op, they're going to look at the patient's condition after surgery, all right? What type did they do using the blood products? What type of medication and all this kind of things that they use to manage that patient in surgery. They're going to also dictate an op report. And the same thing for your anesthesia, they also dictate an anesthesia report as well. So these are notes, but they also do in a report. And so we saw figure 622A on page 163. That's your anesthesia report, or your anesthesia record. Your joint commission tells you in terms of your anesthesia record, it requires your pre and your post anesthesia record. Your COP also requires documentation of a pre-anesthesia and post-anesthesia. Your Medicare COP says that pre-anesthesia eval note needs to be within 48 hours prior to surgery, needs to be completed. Then they have to also maintain an intra-op record as well as a post-anesthesia evaluation no later than 48 hours after surgery. All right, so we got some time frames there that needs to be there. They also need to do one for your recovery room. When that patient goes to recovery, they're going to have a recovery room record. And let's see, do we even have? Let me see if I have one for. I don't think I have a recovery room record figure. But yes, so they need a recovery room record where they document what kind of medication, anesthesia agents administered during operative procedures, evaluation, post-op, pre-op, recovery of the patient from anesthesia during immediate post-op period, those type of things. You also have, so we talked about your notes for your operation and your anesthesia, but you also, and I mentioned you have to have an operative record, and so there on 162, it kind of outlines, we sort of mentioned some of this already, but then I go back and tell you pretty much what your Joint Commission and your COP has outlined as to why we are doing what we do. So just like the anesthesia record, your operative record is also required through Joint Commission and COP, and they tell you that it needs to be documented prior to performing surgery. The Joint Commission also further tells you about if there's a high-risk procedure, and a high-risk procedure report should be written or dictated upon completion of that procedure and before that patient is transferred to the next level of care. Now, if that physician accompanies that person to the next level of care, then the report can be written or dictated in the new unit or area of care. All right, so I think I've already showed you the figures there. Figure 623 on page 166 is an example of your operative record. Page 166, figure 623. Okay? Lots of stuff going on here. All right. All right, so we already covered the operative record. Okay, let's look at pathology report. I don't think we talked about your pathology report. So Joint Commission also tells us we have to have an authenticated data report or examination performed by pathology and clinical laboratories services. And so basically a pathology report is where, say that there's an operation that occurs and they take a biopsy or a section of tissue, and they want to look at that tissue either to, they want to help to come up with a diagnosis for a patient. Or they want to analyze that tissue to determine whether it's cancerous or some nature or something of that nature. And so that tissue is removed from surgery in the sense of pathology. So when that happens, then there's going to be what we call a pathology report. Figure 624 on page 167 is an example of a pathology report. You'll start seeing them talk about different types of specimens, looking at tissues and different types of views. You'll see something like where they say a macroscopic and a microscopic examination. So macro means gross, or micro is small. So macro is big, micro is small, examination of tissue. All right, it has to be completed usually within 24 hours following that patient's record. And so you'll see when they did the examination, what's the clinical diagnosis, what tissue was examined, what's the pathologic diagnosis, and like I say, macro and micro examinations. And then your pathologist is the person who's going to authenticate a pathology report. Your book talks about the post-anesthesia care unit, and we kind of already mentioned that. I'm just sort of following here. That's your recovery room record. Figure 625 on page 169. This is an example of a recovery room record that we were talking about. Right? Well, basically, they're just monitoring that patient when he just right off of anesthesia. Okay? And on page 168, it gives you some bullets of everything that's included in a recovery room record. So you need to take a look at that. Now, ancillary reports, we're still in clinical documentation. Ancillary reports are all those departments sort of like your lab, your radiology, nuclear medicine. These are what we call ancillary departments. And so the reports that they generate is what we call ancillary reports. So when they get x-rays done, or you do some kind of lab work like on urine, blood, or some type of body fluid, and you get lab, this is the type of report to be generated. And usually these need to be filed on that patient's record as soon as the interpretation has been made. That's usually 24 hours, within 24 hours. If you look on page 171, figure 626A, this is an example of a lab report. So usually when you see that, you will see different types of what I want to call that. I'm kind of short on words there, but you'll see stuff like your sodium, your potassium. I forgot what you call those things that are in your body, and you'll see the different levels. They usually give you a baseline, and they're testing those things to see if it's high or low or whatever. But you'll see those types of things. Let me see what I want to call it. When they take your specimen, and you see the different lab values for the different elements in your body, like your glucose, your sodium, your potassium. I couldn't think of a word for that. Because Table 6.8, page 170, gives you a lot of those ancillary reports. So this is an example on page 171 of your lab report. That's going to look different from your radiology report, which is on page 172, figure 626B. All right? Because mostly they usually start talking about views on like an image, like the X-rays or brain scan or something of that nature, and you'll see the findings on it, PET scans, those types of things. So your lab is more like blood levels, measures, and things in your blood and your urine and those types of things. And then you got your heart type thing, EKGs, ECGs, and all those kind of reports as well. You got figure 626C on page 173, EKG report. Figure 626D on page 174 is electroencephalogram, which is an EEG. And then on page 175, figure 626E is an EMG, electromyogram. So all of those would be considered ancillary reports. Now, nursing documentation. This is going to be the biggest area because nurses provide 9% of all the care that's going on in the hospital. Joint Commission requires the nursing assessment, nutritional screening, and functional screening to be within 24 hours after the inpatient admission. So there's a time limit there. Your nurses, they monitor vital signs, they give medication, they look at different, they have flow charts that they use to look at different things like urine flow, urine output and input, and drinking input, fluid, that's what I'm trying to say, fluid input and output, and the progress of that patient. So they have lots of reports that stem or generate from your nursing department. If you look on page 177, figure 627A, this is the nursing care plan that stems from that nursing assessment. You also have 627B on page 178. This is the nursing progress note. Figure 627C on page 179 is the nursing discharge summary, because most of the time when the patient is discharged, all these different areas have some semblance of a discharge note or summary or something that they do in line with the discharge. Figure 627D is a flow chart for the vital signs. A lot of times nurses will use flow charts or graph sheets more often because it's very easy for comparison, because they're always documenting a lot of different numerical values in which they want to compare. So they like to use a lot of graph sheets or flow sheets. Figure 627E is a medical administration record, or MAR. You might see that called MAR, that your nurses a lot of times they're going to fill that out as well. If you look at table 6.9 on page 176, it shows your nursing documentation that they're involved in. You know, and it aligns with those different figures that I just pointed out. All right, there are also special reports. This will include your obstetrical record and your neonatal record. So your obstetrics record that's your mother's record, whereas your neonatal record is that newborn record. When you're looking at your obstetrical record, you're going to include your antepartum, that's before the birth, and this starts in the physician's office with the prenatal care and what have you. And then you got your labor and delivery record, so that's during the delivery. And then you got your postpartum record. That's after the mother has gave birth. Your neonatal record, that's your baby's record. So you're going to see your birth history in that record, newborn identification, newborn physical exam, and newborn progress note. APGAR scores are included in your newborn record. And with your APGAR, that's when they look at, run some tests in terms of what that baby's health is right after birth. So they look at their skin color, muscle tone, breathing, respirations, and those types of things, and they give them what we call an APGAR score. They measure the APGAR at 1 minute and 5 minutes after birth, and they can do it up to 10 to 15 minutes. If the APGAR is not where it's desired, then a lot of times that's when they're going to do some type of intervention. Maybe come in with some critical care, resuscitation, and different types of things that they go in to do once that baby is not performing or as needed. Autopsy reports are another component of a record. The conditions of participation say that the staff should attempt to obtain autopsies in all cases of unusual death and to pursue medical, legal, and educational interests. Right? So they have to do an autopsy report on deaths that are suspicious or unusual. So in an autopsy report, you see microscopic and microscopic examinations of the organs and tissues. You have to receive a consent from the legal next of kin of the deceased in order to do an autopsy, or if the coroner orders one, they can do it in that case as well. And so they have to provide that documentation on the patient record. And basically, until that autopsy report is on their record, that record is going to be incomplete. So they kind of look at that patient's clinical history, what the results of their examination on the microscopic level, what things led to that person's death, are there any clinical pathologic correlation, and then the pathologist is the one who's going to authenticate that autopsy report. Your book also outlines several instances in which an autopsy will be required. If the cause of death is not related to treatment, if they are dead when they arrive to the emergency room, sudden infant death. So they give you a whole listing of different things that would initiate a autopsy needing to be completed. Let me roll back. Figure 628. That was an example of a neonatal record. I'm sorry that I didn't mention that. And I also was of interest if we roll back when we're talking about the nursing. Figure 627F on page 186. This is a bedside terminal that the nurses often use when they come in to see the patient. If you've ever been in a hospital or been in with a family member, you might see them typing on that where they're entering a lot of that pertinent information on the patient right at the bedside. Figure 629B on page 187 was an example of them taking the newborn footprints when we're doing a neonatal record. Figure 629C on page 186 is an example of a postpartum record. See, that was back looking at the mother's record, the obstetrical record. So make sure you take a look at those. Again, there's figures all over this chapter. It's chock full. So figure 630, because we were just talking about the autopsy report, figure 630 on page 188 is an example of an autopsy report. Okay? Now, we're going to kind of change tune because we've been talking about your inpatient record. So let's look at hospital outpatient. We were talking about hospital inpatient. With your hospital outpatient, we're talking about records that do not include an overnight stay. So you could be your rehabilitation services can be done on an outpatient basis. You can have diagnostic therapeutic type services that occur on an outpatient basis. And so they will also include like a patient registration form. They can have test results from those ancillary departments in a hospital outpatient record. They will have a history and physical exam, progress notes, physician orders, nursing documentation, all can be included in a record. They say a lot of times in your short stay record, you can see all of that on one double-sided form. Figure 631 on page 189 is an example of a short stay record for hospital outpatient. Emergency room records are considered your considered a hospital outpatient record. Now, we talked about data sets, and with the hospital, they use a UHDDS, but in an ambulatory care, they use what we call Uniform Ambulatory Care Data Set, UACDS, and basically it's the same principle behind it, but it's just for ambulatory versus a hospital, but this lays out the minimum core data that needs to be obtained or captured in an ambulatory setting for outpatients. Your book also explains the difference between outpatient visit and encounter and ancillary visit. So basically, your ancillary visit kind of stems from what we call an encounter. So your encounter is when that person goes in and has that professional contact with that provider, the patient does, and then from that encounter, that patient may be referred to some type of ancillary service, and that's what we call an ancillary service visit or occasional service. All right. All right, so that was a hospital outpatient record. Now let's look at a physician office record. All right, so that's outpatient as well, but it's not hospital outpatient. So you got physician office record. It also contains patient registration, a patient registration form. It has a problem list. We kind of talked about problem list before. They also have a medication list. They'll have progress notes, and they also have ancillary reports. And ancillary reports means the same things we discussed in our hospital inpatient as well as in our hospital outpatient. That means your lab, your x-ray, radiology, and those types of reports. Also, you're going to see in a physician office record is something we call an encounter form. You may hear it called a super bill. You may hear it called a fee slip, a charge slip. All of these will be the same thing. And basically, this is that form that they use to capture all the charges on. It's usually a single page, and it's going to list all of the procedures that are commonly done at that physician's office, and you're going to see CPT codes, which is your current procedure terminology codes listed next to them, and that doctor or that provider simply indicate which one that they perform with that patient, and it goes back to that front desk. So it's usually initiated when that patient goes to that physician. They get that form and they bring it. That's that form they you bring back to the front desk after you've seen the physician. If you look at figure 632A, page 192, this is an example of a patient registration form. Figure 632B is an example of a problem list, and we actually talked about problem lists before. Figure 632C on page 194 is the medication list for a physician office record. Figure 632D, page 195, is the progress notes for a physician office. And then figure 632E on page 196 is ancillary report form for a physician office record. All right, so those are all our figures. Table 610 on page 191 gives you your descriptions of those different documents that we just briefly covered. Now, the one that's at the end there that I haven't mentioned was your immunization record, and we already know what your immunization. Those are those vaccinations that children get, and then you got growth and development charts that you can also see. You have Figure 632F on page 197 showing you an example of an immunization record. So you see your DTaP and your Hep B's and things like that. Those different vaccination shots that you get in a family physician type office. On page 198, 199, those are your growth charts, and those should be familiar, especially those of you who have kids and yourself, if you've been a kid at some point. Then Figure 633 on page 200 is the encounter form that I was describing to you. So you see here how you have the different types of procedures that they perform, and then you see those 5-digit numbers. Those are your CPT codes on your encounter form, and this may be familiar to you if you visit a physician office and they hand you this form that they send back to the front when you get ready to pay. This is the form they actually use the code off of and those types of things. That's why it's called a super bill or a fee slip. Now, our final concept for this presentation is forms control and design. And basically, this is talking about the forms that all these forms we looked at, someone had to either develop those forms or that facility may have outsourced to some vendor or some commercial provider who already has some type of forms developed. But either way, there has to be some mechanism to design forms, and then you have to have some type of control mechanism for them as well. So a facility may have one individual person who they designate to be responsible for the control and design function. A lot of times it usually may be the health information department or what we call a forms committee that they have to oversee this function, to look at those forms, design them, approve them, and have some kind of control mechanism for them. Basically, when they are developing a form, we're looking for we're trying to obtain quality information. That's the whole purpose of the form. So your information that you obtain from that form is only going to be as good as the form that has been designed. That form is going to give you back whatever you have created. So when they are proposing to use a form, they want to make sure that they're not duplicating or any of the information that's already on some other form. So you want to make sure that the use of the form is going to be very efficient. And so if we have duplication, we want to consolidate those things. We also want to make sure that we are in compliance with any of our regulatory laws, rules, legislation through our any type of organizations that provide standards for us. So we got to make sure we're in compliance. We also want quality documentation, and I was just kind of alluding to that fact. And we want to have we want to streamline that forms approval process. All right. So when we're looking at designing a form, what are things we want to specifically look at in terms of doing what we just talked about? You want to make sure you know what is the purpose for this form. That's what you want to know. If we're not going to duplicate or whatever, we got to figure out why do we need to create this form. What are we trying to do with this form? And whatever we're doing, we want to make sure we keep it very simple. When you get too complex, that's when you make mistakes. You also, in all your forms, you want to have the title of that form. You want to have a form number. When was the original date that this form was created? And you also want to have revision dates. Revision dates are very important. On a personal level, if you are creating forms and say you create one version, now you got another version, you end up with 3 or 4 versions, you don't even know which one is the most recent. So revision dates are very important because I found myself in that situation. You also have to have a section where you're going to include that patient identification, because we already talked about the standards that require patient identification and facility identification to be on that form front and back. All right? Pre-printed instructions are important. Make sure you plan the spacing on the form. You need to know how large the margins need to be, what type of font is going to be used. Are they typing in there? Because your spacing on your form, you need to know, are they going to type in the form, or are they going to have handwritten? Because you have to have different spacing, or you have different spacing needs based on how they're going to enter information in that form. You also need to be interested or concerned with color coding. A lot of times, white paper, black ink is the best, because if you're going to do a lot of photocopying, sometimes different colors don't come through very well when you're faxing or copying or photocopying a form. You also want to keep uniformity in size, content, and appearance. All your headings should be standard format. You need to look at the weight and quality of paper you're going to use. If you got a form that's going to be heavily rotated around or used or disseminated, then you might want to have a heavier weighted paper that's going to withstand all that usage. Also, you may want to have a pilot to put that form to a trial use, maybe to evaluate if this form is going to actually be as efficient and effective as we need it to be. If it's not, then you need to make necessary revisions. And as I mentioned before, some people adopt to go purchase ready-to-use forms versus creating or designing forms in-house. If that's cheaper for your facility's needs, then so be that. Consider printing patient identification when form is generated for patient safety purposes. So these are some of your considerations in terms of designing a form and things you need to look at to have the best form that you could possibly have. Now, this is going to conclude my presentation on Chapter 6, Content of the Patient Record, Inpatient, Outpatient, and Physician Office.